All right, so you've used the HINTS exam and you've confirmed it, a peripheral cause of vertigo. Now, with that diagnosis locked in, the clock is really ticking. So let's dive into the absolutely critical management decisions you need to make in these first 72 hours to completely optimize your patient's recovery.
So the exam's done. You saw it yourself, the head impulse test is abnormal, the nystagmus is unidirectional, and there's no skew. It is clearly peripheral. But what you do right now in this immediate acute window is going to have a massive impact on your patient's outcome for weeks, maybe even months to come. So what are the 3 most important moves you need to make?
It really all boils down to 3 key things that make up the core management package. First up, the big question of corticosteroids. Should you use them and when? Second, how do you control those awful symptoms without actually getting in the way of recovery? And third, when is the right time to kick off vestibular rehabilitation? If you can get these 3 right, you have set your patient on the absolute best path forward.
But before we start building that ideal package, we have to talk about the 2 biggest traps you can fall into. The most common management mistake is something we'll call the suppressant trap. It's the well-intentioned but ultimately harmful overuse of antiemetics. And then there's the most dangerous diagnostic error, even after you get a peripheral HINTS exam. It's the icon mimic, and that's when you miss a specific type of stroke that looks exactly like labyrinthitis. Let's tackle that management trap first.
Okay, the suppressant trap. It is so incredibly common because, honestly, it feels like the right thing to do. Your patient is just miserable, they're nauseous, they're vomiting, and giving them something to stop all that just makes sense. But the evidence here is crystal clear. There's a very, very narrow therapeutic window.
And here it is. This is the magic number, 72 hours. That is the absolute maximum, the absolute max, that a patient with acute vestibular lymphopathy should be on a vestibular suppressant, like prochlorperazine or promethazine. And really, ideally, it's even shorter, more like 24 to 48 hours. So why are we so strict about this?
What's really fascinating here is how the job of these suppressants just totally flips over time. In that initial window, that first 72 hours, they're a lifeline, right? They control symptoms, they let the patient stay hydrated, they let them get some rest, but the moment you cross that 72-hour mark, they switch from being helpful to being actively harmful. They literally delay central compensation. That's the brain's ability to adapt to the wonky new signal from the inner ear. And the consequence of that? The symptoms drag on for longer and you've got a much higher risk of chronic dizziness.
And the literature is just so emphatic on this. This quote says it all, perfectly. This isn't some minor mistake. It is the single most important, and honestly, the most common management error that we see out there. The crucial takeaway is simple. Suppressants are in for a maximum of 3 days, and then they have got to come out.
All right, so pivoting away from the management trap, we land right on the diagnostic one, the AICA mimic. AICA stands for the anterior inferior cerebellar artery, and let me tell you, a stroke in that artery's territory can be clinically indistinguishable from labyrinthitis. This is where the stakes get very, very high.
This pathway just brilliantly lays out the critical fork in the road. You've confirmed a peripheral pattern with HINTS. Perfect. The very next question you must ask is, has there been any change in your hearing? If the answer is no, you go right down the vestibular neuritis pathway. But if the answer is yes, well, a whole new world of possibilities just opened up.
And this right here is the rule you absolutely have to commit to memory. If your patient has acute hearing loss along with their vertigo and they're over 50 or have any vascular risk factors, we're talking hypertension, diabetes, smoking, you must assume it is an ICA infarction until you've proven it's not. In this group, labyrinthitis becomes a diagnosis of exclusion.
So what does this mean in practice? It means you have to activate a parallel pathway. That patient needs an urgent MRI with diffusion-weighted imaging. That's the only reliable way to spot a posterior circulation stroke. A CT scan of the brain is basically useless here. You cannot use it to rule out a stroke. At the exact same time, you're referring them to the stroke or neurology team. This has to happen in parallel with an ENT review, not one after the other. Time is absolutely critical here.
Now, why are we so worried about this? Well, because it's not some rare thing. Data from Lee and colleagues back in 2009 showed that a staggering 95% of patients with a confirmed ICA stroke showed up with audiovestibular symptoms. It's the classic presentation, not some weird, unusual one. So if you see vertigo plus hearing loss in an at-risk patient, you have to be thinking ICA.
Okay, so now that we've navigated the 2 biggest traps, let's put together the positive, evidence-based management plan. It really rests on 3 solid pillars, and you need to get them all started in the first few days.
Pillar number 1 is corticosteroids. The evidence strongly supports starting a short course of oral steroids within 72 hours of when the symptoms first started. And this isn't just about making people feel better faster. It's about improving the objective, long-term physiological recovery of the vestibular nerve itself.
And here's the landmark data to back that up. This chart is visualizing the results from the 2004 Strupp trial, published in the New England Journal of Medicine. What they did was measure caloric function, which is an objective test of the vestibular nerve, at 12 months. And the group that got steroids had significantly better recovery of their nerve function compared to the placebo group. It's really one of the most solid pieces of evidence we have in this entire field.
So, what's the actual prescription look like? Well, a really common and effective regimen is prednisone, 1 milligram per kilogram up to a max of 60 milligrams once a day for 5 days. Then you follow that with a taper over the next 10 to 15 days. But remember, the key to all of this, it has to be started within that critical 72-hour window to actually be effective.
So let's put it all together. Here is your 3-pillar package. Pillar 1, get the steroids in within 72 hours. Pillar 2, use vestibular suppressants for symptom control, but make sure they're out within 72 hours. And Pillar 3, get them moving early with mobilization and rehab exercises, all started within that first week.
So look, if you take nothing else away from this, please remember these 3 rules. Get steroids in by 72 hours. Get suppressants out by 72 hours. And if hearing is lost in an older or at-risk patient, your very first thought has to be an ACS stroke. I promise you, these 3 principles will fundamentally change your patient's outcomes for the better.
Okay, so we've covered the acute management, but what happens next? In our final explainer, we're going to explore the recovery timeline, what predicts a good outcome, and how to manage the most common long-term complications, like secondary BPPV and PPPD.
Thanks so much for joining us. To help you put all of this into practice, you can find downloadable clinical pathways and patient handouts right on our website at australiandizzinessclinics.com. And please, don't forget to subscribe so you don't miss the final part of our series.